So, good evening, everyone. Thanks to Indian College of Cardiology for giving me this opportunity. I'll be speaking on triple or dual antithrombotics in acute coronary syndrome patients with AF who are undergoing PCI. So, atrial fibrillation and coronary artery disease, they both have overlapping patient populations, and also they have overlapping indications for antithrombotic therapy. Individually, they have a challenge in CAD patients as well as atrial fibrillation patients regarding the antithrombotics, the bleeding risk, the ischemic stroke risk, further ischemic events risk, and the cost of the medicine. But when these two factors are there in a single patient, then the challenge becomes multifold. So we'll discuss these two patients. Patient A was a young gentleman who came with mild chest pain and minor elevation in troponin. This patient had a bad family history. He was a smoker and he was also having LDL of 252. And you can appreciate the patient had a triple vessel disease. Patient B came with severe chest pain with markedly elevated troponins, but he did not have any family history of coronary artery disease, and he was non-smoker, non-diabetic. A patient was treated with 5 stents, and B patient was treated with single stent. So patient A, who had a family history, who is dyslipidemic, probably familial hypercholesterolemia, his LDL was 252, he's smoker, and triple vessel disease with 5 stents, and patient B was single stent with no family history, no significant risk factors. So both these patients' future outcome will be different, and a strategy which is one size fit all approach will not you go for these two patients. So we have to be having a precise kind of medicine and a strategy for each patient. That is the reason why we have bewildering number of strategies in the ACS patients with atrial fibrillation, starting from aspirin, its dose, how long aspirin should be given, P2Y12 inhibitors, which P2Y12 inhibitor, how long, oral anticoagulants, whether vitamin A, K antagonist or new oral anticoagulant, how long, and then these, if we put it all together, these all possibilities. There can be 2.8 million possible combinations throughout 1 year. So the idea basically with all this combination is to prevent these all three: stent thrombosis, stroke, and major bleeding, which is very difficult to simultaneously control. And the guidelines, the clinical practice, what we the judgment, it's all guided by these 4 trials which have come in the last 1 decade. And before going to these trials, let me talk about OS trial. Basically, this was a trial which gave us this concept that if we drop aspirin early, it is not going to increase the ischemic events, but it is definitely going to reduce the bleeding events. And although it was a very small trial, 573 patients were there, but it set the stage for future trials on this concept. Then the Pioneer AF PCI trial came. It had enrolled 2,100 patients, and it had 3 arms. The one arm was rivaroxaban 15 mg with clopidogrel. The second was rivaroxaban 2.5 mg twice daily with aspirin and clopidogrel. And third was the usual triple therapy. The patients were randomized within 72 hours of sheath removal. And the results kind of validated the finding what we saw in the OS trial. And the rivaroxaban plus P2Y12 inhibitor gave the least bleeding with no significant decrease in the ischemic stroke and ischemic events. The third trial which came, redual PCI, it was a little larger trial. It enrolled 2,500 patients. And here dabigatran full dose, 150 mg twice daily, was given with P2Y12 inhibitor. And a smaller group of patients were given dabigatran etixalate, 110 mg BD with P2Y12 inhibitor. And it was compared with the third, usual triple therapy. And the patient was given aspirin up to 1 month in those patients where bare metal stent was implanted, and in 3 months where dragonic stents were used. This trial also showed that both the doses of dabigatran showed lesser bleeding. Dual therapy was giving lesser bleeding than triple therapy, and there was no increase in ischemic events. So by this time, it was very clear that dual therapy was giving us less bleeding without compromising the ischemic endpoints. But it was not clear which was the driver, whether dropping aspirin was driving the less bleeding, or whether NOAC was driving the less bleeding as compared to vitamin K antagonist. So the Augustus trial, which was the largest of its, of this field, or maybe the best designed trial, it randomized 4,614 patients, and it was a 2:2 factorial design, trial. And the randomization was done not sequentially; it was simultaneous randomization was done. The patient was grouped in either apixaban 5 milligram twice daily or VKA, and these groups were further subdivided into aspirin and placebo arm. And the results, the apixaban group showed significant reduction in bleeding with NNT of 24, and aspirin versus placebo arm, the result was simply jaw dropping. As we see that there was significant reduction in bleeding with NNH of only 14. And it was seen in all across patients, whether it was the patients were medically managed or the patients were, underwent PCI, as we discussed, our topic is, or the patients who were having elective PCI after some time. So there was no difference. Every time in all the strategies, the bleeding, the events were lessened. The secondary outcome, death or hospitalization, was not much different. But at the same time, it was very clear with this Augustus trial that aspirin was the major driving force in, in the bleeding reduction. But when to stop aspirin is an important issue, and that is what insights from Augustus we can make out some strategy. So overall, the first thing is ischemic events happen very less frequently as compared to bleeding events, and that is why most of the trials, they are underpowered for ischemic endpoints. Stent thrombosis, myocardial infarction, urgent revascularization, although it was more or less similar in aspirin plus placebo arm, it was very clear with this trial that the thrombotic events, especially stent thrombosis, was confined majority of the times within 30 days of randomization. And after 30 days, the ischemic events were lesser. So this is the trade-off between bleeding and ischemic events. The bleeding risk is cumulative and is higher with long-term potent antithrombotic therapy, but ischemic events tend to be recurrent, but it occurs early after ACI and ACS and PCI, subgroup of patients. This is, from 0 to 30 days. In this sub-study, they divided the bleeding as well as the ischemic events into severe, intermediate, and a broad category of patients. So the bleeding outcomes, severe bleeding outcome was definitely higher in, with aspirin in 0 to 30 days, but as well as the intermediate and broad, category, bleeding episodes. But as far as ischemic outcomes were concerned, the broad ischemic outcomes were not different, but there was only the mild difference in the ischemic outcomes in severe events. But when it came to 30 days to 6 months, the bleeding risk was, it remained there. And you can appreciate from this slide, the broad as well as intermediate, as well as severe, all category of bleeds were higher with aspirin, but ischemic outcome were more or less similar. There was not much of difference. This is the Kaplan-Meier curve showing the same thing. After 30 days, probably aspirin and placebo is not going to give any difference in ischemic outcomes, but the bleeding risk remains there. So with this, with all these trials, we can conclude that after PCI, triple therapy can be switched to dual acutely or maximum within 30 days. And there is no additional benefit with aspirin after 30 days in terms of ischemic risk reduction. But definitely the bleeding risk gets higher and higher. Patient characteristics add on to the decision making. So all these, disparity in the guidelines which were there till 2018-19, as most of the EAC guidelines, they kind of recommended 1 month of triple therapy, followed by dual therapy in ACS patients who are going PCI, then up to 1 year of dual, therapy. But in North American expert consensus document way back in 2018, they had suggested this strategy of only peri-PCI triple therapy. as a default strategy, followed by dual therapy up to 12 months, followed by oral anticoagulant. And this is what has been accepted by ESC as well. And probably it is being driven by the Augustus sub-study and Augustus trial. And they also now recommend in their recent ESC 2020 guidelines, as if patients undergoing PCI for acute coronary syndrome patients, triple therapy should be given for 1 week, up to 1 week, followed by a dual therapy, provided until unless the patient is having very high ischemic risk. If the patient is having high ischemic risk, like the patients we saw, patient A, we can extend the triple therapy to 1 month. But as a default strategy, 1 week of triple therapy is probably what is default strategy should be for all the patients. Patient's characteristic and the risk factors, and probably with all these guidelines, we can reach somewhere close to our antithrombotic sweet spot. Thank you so much for the patient hearing.